Welcome to this special edition of Diabetes Core Update, where we will discuss diabetes and hypercortisolism. If you didn't listen to our first podcast of this series, you might be asking yourself, why are we discussing hypercortisolism? It is vanishingly rare. Well, in our first podcast, we answered that question that you have, and we discussed the Caviness study that showed that people with uncontrolled diabetes, in that group of people, the prevalence of hypercortisolism is approximately 24%. Now, again, the inclusion criteria were very specific, and we'll talk a little more about that later. Today, we're going to discuss information that was recently presented at the ADA's scientific sessions showing that treatment of hypercortisolism makes a difference. This is important new information. I'm your host, Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. This special series of Diabetes Core Update is sponsored by Corcept. Joining us for today's episode is Dr. John Buse. Dr. Buse is the Verne S. Caviness Distinguished Professor and Director of the Diabetes Center at the University of North Carolina at Chapel Hill School of Medicine. He has been President for Medicine and Science at the ADA. He is a recipient of the ADA's Outstanding Achievement in Clinical Diabetes Research Award. He has authored more than 500 publications, yes, I said 500, and participated in and led numerous clinical trials. Welcome back, John.
It's a pleasure to talk to you again, Neil.
John, I want to ask you a question. When the prevalence data from Catalyst was originally presented, and that's almost a year ago now, and you've been involved in a lot of trials, and whenever you do trials, you don't really know what the answer is going to be, but you have an idea. Is it just that I have been naive about this, or were there many times when you were as surprised as you were with the prevalence data on hypercortisolism in uncontrolled diabetes?
Not only was I surprised, but there were about 30 investigators in the trial, and as we did our trainings around how to execute the protocol and that sort of thing, we did a little straw poll of what people thought the prevalence would be. And most people were in the low single digits, 1, 2, 3%. In retrospect, there were some studies from other countries, smaller studies, not done exactly like ours, that suggested that we probably should have been guessing higher than that. But no, there are very few things that I've been as surprised about as the prevalence of hypercortisolism and difficult to control diabetes. But the studies that we presented this year at the ADA were important because they show that there's a path. So we should be looking for hypercortisolism because now we have a path to better treatment of diabetes in recognition of the hypercortisolism.
Yeah, and that's such an important point because it's one thing to identify a problem, but if you're going to start looking for a problem, you better have an idea what the solution may be. And we'll talk a bit more about that as we go through the podcast. We know that a lot of people don't have their glucose controlled to goal. In fact, Ralph DeFranzo opened the scientific sessions presentation of the second part of the Catalyst trial, talking about the number of people not to goal. And I think the number he gave that were not controlled to a goal A1C of 7 was about half of everyone out there. He also used, looking at epidemiologic number, a goal of 8%, and it was less, but it was still a significant number of people not controlled to goal there. And obviously, if our patient doesn't have good glucose control, the first step that is worth reminding all our listeners is really to ask about adherence. And I think it was C. Everett Koop, the Surgeon General in the 1980s, who famously said, people don't get better from medicines they don't take. And I often think about that because it is hard to be on the medical regimens that our patients with diabetes are on. They're on multiple medicines for not just glucose, but also for hypertension, for cholesterol, and we check that first. Having checked for that, though, there still are a lot of patients who are not controlled to goal. And when should we think about testing for hypercortisolism in that group? And once we decide to test, how do we go about doing that, and how do we assess those results?
Yeah, in the trial, we had very specific entry criteria. So it was an A1C above 7.5, despite 3 glucose-lowering medications, or 2 glucose-lowering medications with one of them being insulin, or 2 glucose-lowering medications and at least 2 blood pressure medicines, or 2 glucose-lowering medications and a complication of diabetes, either microvascular or macrovascular. So those were the entry criteria. But the gestalt that I got from this study is that the more problems a person has, on top of their diabetes, they have hypertension. On top of their hypertension, they have dyslipidemia, so they have hypertriglyceridemia or low HDL. They have central obesity, they have anxiety, they have depression, they have pain. So just about every layer of complexity was associated with an increased risk of hypercortisolism. And the number of medications, and particularly if you have a patient that's on multiple diabetes medications and not reaching their goals, or multiple blood pressure medications and multiple diabetes medications, or you're adding fibrates, the more complicated the person, I think the higher risk it is that they have hypercortisolism. Cortisol works in every cell of the body. It's essential for survival, but too much of it is bad for just about everything we know about.
That gestalt is so helpful to translate the specific criteria, which at least many of us in primary care won't remember those specifics, but I think we can all remember the gestalt that you just went over.
And the other thing I would add, and you were intimating this, is that when you think a patient is non-compliant, I usually say something like, it took me 10 years to be good at taking my cholesterol-lowering medicine and my blood pressure-lowering medicine. I'm good at it now. I have a pill box, et cetera, et cetera. I take it 29 days out of 30, but I was not good for a long time. How good are you at taking your medicines? And if they just won't budge, I do it 7 days a week. I take all my medicines. I do think a lot of people are quite adherent, and whenever you're thinking someone is non-adherent, also think that maybe it's hypercortisolism and I should give them the benefit of the doubt.
I think that's a really good point. There's no advantage for people not to be honest with us as long as we have a non-judgmental approach to what they say. So in the Catalyst study, 24% of people who met those inclusion criteria tested positive. The number was higher, as you said, in people who had other problems along with that. At that point, that was new ground, as you discussed earlier. At that point, we didn't know what we would do with that information. Can you now lead us through the second part of the Catalyst trial that addressed that question, which was presented really just a week ago?
So June 23rd, 3:15 p.m. Central Daylight Time in Chicago. The second part of the study was actually more straightforward. We took the patients who screened positive for hypercortisolism as defined by a 1 milligram overnight dexamethasone suppression test. The next morning, they had cortisol level generally at 8 a.m. and definitely before 9 a.m., and they had a dexamethasone level. And if the cortisol was greater than 1.8, that was hypercortisolism. We measured the dexamethasone to ensure that the patient had taken the tablet and that they had absorbed the tablet and they aren't one of these rare hypermetabolizers of cortisol. And so the level that we used was the upper limits of normal for the assay was 140. And so they had to have a cortisol greater than 1.8 and a dexamethasone level greater than 140. They had that, they had hypercortisolism. Now, to get into this study, we wanted to make sure that they had ACTH independent hypercortisolism. So this generally is of spontaneous adrenal origin. And the way we confirm that is on a separate day, not after the dexamethasone suppression test, but on a separate day, we measured a morning cortisol and an ACTH and a DHEA sulfate. And the low ACTH and DHEA sulfate indicate that ACTH is not the driver of the hypercortisolism. And that puts it in the spectrum that we're really looking for here. If someone has Cushing's disease with a high ACTH and very high overnight dexamethasone suppression test, you'd want to use a different approach than we used.
Right.
We also did an abdominal CT scan. About a third of patients had some abnormality on their adrenals. About a quarter had a single adrenal adenoma that could have been a surgical case. In this trial, that wasn't an option. People decided whether or not they wanted to be randomized in the trial, and then they were randomized to mifepristone or placebo in a 2-to-1 ratio. So 2 patients on mifepristone, 1 on placebo in a blinded fashion. The patients didn't know what they were taking. We didn't know what they were taking. And the mifepristone dose was started at the usual dose, 300 milligrams, and after a few weeks increased to 600 milligrams if tolerated. And after a few weeks, there was an option to go up to 900 milligrams.
Now, John, 2 questions before we go on from there. One, was there a large percent of people that had high ACTH driving this?
No, I don't actually know the percent number, but it was quite low. Okay. Most of the people, the ACTHs were near the lower limits of normal for the assay, and they met the entry criteria for the study. Some didn't. We also excluded some patients that were on medications with drug interactions with mifepristone, so that was another consideration. Some people didn't want to enter the treatment phase of the study. They weren't up for that. So that there were some people that screened positive for hypercortisolism that ended up not being in the trial.
That makes sense. And before we go on to talk about the result, because mifepristone is not a medicine that many of us use very often, it is the same medicine that is used for termination of pregnancy, I believe, but we're not used to using it generally. Can you go over why mifepristone and what it is, how it works?
Yeah, so mifepristone is a cortisol receptor antagonist. It's approved for the treatment of hypercortisolism to lower glucose. So it's actually FDA approved for exactly what we did, but in general, where it's been used is in people who present with hypercortisol more so than looking for people with poorly controlled diabetes and trying to find hypercortisolism. So this is a different look at the same medication. The reason why people don't really know about it is that as you mentioned at the beginning of the show, hypercortisolism in its classic form is a pretty rare disease. So there were 1,000 or so people in the country being treated with mifepristone for hypercortisolism. And here we're estimating that there's certainly more than 1 million people in the United States that might meet the indication for this drug.
What a change. That's pretty phenomenal. So now we know what mifepristone is. We've identified the people with a morning cortisol greater than 1.8 after receiving 1 milligram of dexamethasone the night before a dexamethasone suppression test. What were the results with treatment with mifepristone?
Yeah, so the A1C at baseline for this population was 8.6, and they had about a 1.5% reduction in A1C from baseline. In the placebo group, the starting A1C was a little bit lower, I think 8.3%, but they had a tiny reduction in A1C, 0.15%. So, about a tenth as much A1C reduction. Wow. So the net of that, if you subtract one from the other, you get about a 1.3% greater reduction in A1C. And that is despite the fact that nearly 40% of patients or participants were unable to complete their treatment with mifepristone for the full 24 weeks because of one side effect or another, or mostly related to side effects. And we can talk about that in a moment. and also that the majority of mifepristone-treated patients reduced doses or eliminated glucose-lowering medications during the first 12 weeks of the study. And that included a bunch of the people on insulin reduced the dose of insulin or eliminated the insulin.
Wow.
In the patients that did complete the 24 months of therapy, if I remember correctly, the A1C reduction was closer to 2%.
Wow. And that's pretty phenomenal because typically when you add another medication to someone who's already on 2 or 3 hypoglycemic medications, you don't even get a full percent drop at that point. Is that right?
Yeah, 1.5% reduction in A1C is enormous for a pill. The only drugs that give you 1.5% are insulin and then the highly active GLP-1 receptor agonists and coagonists, tirzepatide and semaglutide.
Yeah. Were there any other important endpoints to be aware of? What was the effect on weight or any other parameters?
So the weight came down on average, different from placebo, about 5 kilos in 24 weeks. So that's 11 pounds. And that was associated with a 5-centimeter reduction in waist circumference. So a little bit bigger waist circumference reduction than you'd expect for 5 kilos of weight loss, which is consistent with the idea that people with hypercortisolism, it's not so much that they're obese, it's that they're centrally obese. So the original case, mini G, that Harvey Cushing described in, I think, 1932, you've seen a picture of her, I'm sure, very rotund, but her BMI was 24. So people often are missing muscle mass. They get muscle wasting. But in any case, so people lost weight. There was also a reduction in BMI, as you'd expect. And then blood pressure was a little bit of a surprise. There's an effect when you block the action of cortisol. If anything, the cortisol levels increase. So you're blocking the cortisol from working. Cortisol levels increase. Cortisol does have activity at the mineralocorticoid receptor. And so there is a funny effect of mifepristone and these cortisol receptor antagonists to sometimes be associated with increases in blood pressure. If this wasn't a randomized trial and we knew we were going to prescribe mifepristone, we probably would have started them on spironolactone at the same time we started them on mifepristone to prevent that effect. So we would have used a mineralocorticoid receptor antagonist like spironolactone, and also to minimize the other adverse effect that was quite common to cause people stopping the drug, hypokalemia.
So that makes sense, which brings us to adverse effects, always an important balance when we think about starting a medicine. Can you tell us a little more about adverse effects of mifepristone?
So the most common adverse effect is something called cortisol withdrawal syndrome. And basically this occurs with any kind of therapy of hypercortisolism, whether you take someone's adrenal out in the setting of adrenal tumor, or you take someone's pituitary tumor out in the setting of Cushing's disease, or you use these cortisol modulating therapies. This glucocorticoid withdrawal syndrome is quite common. In people with very high levels of cortisol, it can be very bad. And so people often treat people who are having their adrenal tumor taken out with cortisol to prevent the glucocorticoid withdrawal syndrome. But we can't do that when you're using a cortisol receptor agonist because it won't work. So people have to tough it out on mifepristone. In the absence of a clinical trial, you could try lower doses by dosing it every other day, or just providing support to the patient where you can tell them with confidence, we're going to start this prescription. You're probably going to feel pretty bad for a few weeks. If you tough it out, when we come around the bend, your diabetes will be better, your blood pressure will be better, your mood might be better, your skin might be better, many things might get better. And so you can support people through that. In the context of a placebo-controlled trial, when someone has nausea, it's a little bit hard to know whether they have a GI bug or they have the glucocorticoid withdrawal syndrome. We just couldn't be quite as definitive about what was going on there. But in any case, a substantial proportion of the patients had this glucocorticoid withdrawal syndrome, and that was the most common adverse event leading to discontinuation. The second most common adverse event leading to discontinuation was the hypokalemia. And again, the latter would have been mitigated in clinical practice by starting with a corticoid receptor antagonist, like spironolactone.
So that makes sense. And that really gives a path forward clinically, because I'm just thinking of another medicine we use very commonly now, GLP-1s. You have to help people get through those first few months. A third of people who get GI side effects, but you get through it because you care about that goal at the end. And this also seems like a goal where, as we talk to people and they understand, it's a goal that they would care about and have buy-in into.
Yeah, absolutely. And the good news is with this drug, mifepristone, it's a cortisol receptor antagonist, but it's not a total antagonist. It doesn't shut off the cortisol receptor. And so my understanding from very experienced adrenal doctors that treat this all the time, that it's almost impossible to cause true adrenal insufficiency, a medical emergency associated with hypotension. People feel bad, but they don't really get into trouble from adrenal insufficiency or adrenal crisis. There are other medications that affect the cortisol system that, for instance, stop the production of cortisol that, if you get too aggressive with the dosing, people can develop adrenal insufficiency.
So we've gone over a lot of information. If you can summarize an approach for our endocrinologists, our primary care clinicians who are listening as a path forward now.
So I think the most important thing to recognize is that this is not the hypercortisolism that you heard about in medical school or nursing school or pharmacy school or whatever school you went to. This is not something you recognize by eyeball. This is something you recognize by history. And the history really is of multimorbidity, all kinds of troubles, and not doing well with regards to their blood sugar control, perhaps their blood pressure control, perhaps their triglycerides, et cetera, et cetera. Psychiatric overlay, people just not doing well. People where you feel like, gosh, I wish I could do something for this person, but everything I tried doesn't work. Or where you're starting to blame the patient and say, I wonder if she's taking that medication. Tirzepatide, arguably the strongest diabetes medication that's ever been invented. Some of the people at highest risk were on tirzepatide. So if you're giving people the really good stuff and they're not responding, that's when to think about it. And if you think about it, it's an easy test, overnight dexamethasone suppression test, measure cortisol and dexamethasone the next day. You don't need to do all kinds of fancy other testing. Do get an adrenal CT scan to see if there's an adrenal nodule that is potentially surgically curable. If not, one thing we showed is you don't need to do all kinds of fancy testing. Therapeutic trial of mifepristone is associated with dramatic improvements in hemoglobin A1C in an intention to treat kind of analysis with nice reduction in body weight. The weight was still going down at 24 weeks, so we don't know what the full effect would have been. And you need some experience in treating patients with mifepristone. In the papers that we wrote, there are references that, from very experienced people in using these medications that can give you some of the hints. I don't think for sure you want to make sure people aren't hypokalemic when you start treatment, and that you may want to consider using spironolactone as you start. Provide them support around the glucocorticoid withdrawal syndrome, and make sure to work with the vendor who there's online pharmacy available that can help with the prior authorization and making sure that the drug interactions are looked at carefully. And they're really excellent at answering questions that come up, they'll take calls from the patient and from providers that want assistance.
This is so helpful and such important information. I have a feeling we're all going to get used to ordering dexamethasone suppression tests over this next year in a way that we have not been doing previously. John, it always amazes me that as much as we know, there's always a new horizon. I actually think of Tennyson's poem, Ulysses, where he says, all experience is an arch where through gleams that untraveled world whose margins fade forever and ever as I move. The more we learn, the more we still have to know, and the more we're often surprised by just ongoing new knowledge. This was so helpful. Any final words you have for our listeners?
Yeah, this is early days. There are other drugs that are being developed that seem to be much better tolerated. There are other drug classes that need to be tested in this setting. And the last possibility that was raised by Dr. DeFranzo is we talked about 24% having hypercortisolism, but there's another 25% that had cortisol levels that were clearly higher than, quote, normal, but they just don't meet the criteria for hypercortisolism. What would those people, how would they improve if they were treated with cortisol-directed therapy? Very few people had a cortisol level of 0, which is what I think my cortisol level would be after an overnight dexamethasone suppression test. So it may be that hypercortisolism is playing a role in a much bigger slice than 23.6% of the population of difficult to control diabetes.
Dr. John Buse, thank you so much for joining us.
It's been a pleasure. I'll talk to you any day.
Thanks so much. And most of all, of course, thanks to our listeners. Thank you for joining us on this second of a 3-part series on hypercortisolism in difficult to control diabetes, a critically important emerging concept and exciting advance in the management and diagnosis and treatment now of people with uncontrolled diabetes. This special series of Diabetes Core Update is sponsored by Corcept. We thank you for listening. For the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.